The evolution in screening for Down syndrome over the last 45 years, starting from maternal age as the method of screening in the 1970s and evolving in the last couple of years into cell-free DNA analysis of maternal blood. The first method of screening introduced in the 1970s was that based on maternal age. We knew that as women get older, their chance of having a baby with Downs increases, and it was at that time decided that all women over the age of 35 should be offered the option of invasive testing. In the 1970s, about 5% of pregnant women were over the age of 35, and this group contained about 30% of all fetuses with Down syndrome. So as a method of screening, the performance of maternal age had a detection rate of 30% and the screen positive rate, which has come to become synonymous in screening for Downs with the false positive rate, was about 5%. In the 1980s, it was realized that a series of fetoplacental products in the maternal circulation are altered in pregnancies with Downs, and therefore the measurement of these serum metabolites was combined with maternal age to develop a more effective method of screening. Depending on which combinations of different metabolites were measured, the detection rate increased from about 30% based on maternal age to between 60 and 70% in various combinations of maternal serum, alpha-fetoprotein, estriol, free beta HCG, and inhibin A. In the 1990s, we came to realize that in a high proportion of fetuses with Down syndrome, the nuchal translucency thickness in the 12th week of pregnancy is increased. And maternal age was now combined with the measurement of nuchal translucency to develop a method which could detect about 75 to 80% of fetuses with Downs at 11 to 13 weeks of pregnancy. And by the end of the 90s, the beginning of the 2000s, another method was introduced where maternal age was combined with the measurement of nuchal translucency and maternal serum free beta HCG and PAB-A to achieve now a detection rate of about 90% for a false positive rate of 5. In the last 10 years, a series of other metabolites have been examined, including a low maternal serum alpha-fetoprotein and placental growth factor in pregnancies with Downs, and a series of ultrasound additional markers at 11 to 13 weeks, including the absence of the nasal bone, tricuspid regurgitation, increased resistance to flow in the ductus venosus, and increased velocity in the hepatic artery. When we combine these additional biophysical and biochemical markers, we can achieve detection rates of 97% and simultaneously reduce now the false positive rate to about 3%. The first trimester combined test is not only useful in singleton pregnancies, but it can also be used effectively in screening for Down syndrome in both monochorionic and dichorionic twin pregnancies, provided people realize that the free beta HCG and the PAB-A increases with gestation in twin pregnancies, and the levels are not exactly double as those in singleton pregnancies. The combination of biochemical markers with nuchal translucency can achieve similar performance of screening in twins as in singletons. The only difference relates to monochorionic twins, where a discordancy in crown rump length and nuchal translucency may not be merely a marker for Downs, but also an early marker for twin-to-twin transfusion syndrome. And therefore, in monochorionic twins, the false positive rate is a bit higher than in dichorionic twins. I now want to discuss the additional benefits from the introduction of the first trimester combined test. The most obvious advantage relates to a shift in prenatal screening and diagnosis of chromosomal abnormalities from the second to the first trimester of pregnancy. This is clearly beneficial for women where the baby is found to be chromosomally abnormal and they choose to have a termination, because this procedure in the first trimester is safer. For the vast majority of the population, where screening is undertaken primarily to reassure them that the baby is unlikely to have a chromosomal abnormality, the reassurance comes earlier in pregnancy. Other advantage of screening in the first trimester relates to the detection of additional chromosomal abnormalities other than Downs. Trisomy 18 and 13, the second and third commonest aneuploidies, are sharing with Downs three things. Firstly, all three increase with maternal age. Secondly, in all three, maternal serum Pabay is decreased. And thirdly, in all three, the fetal nuchal translucency is increased. Therefore, in screening for Downs, we are identifying about 75% of the fetuses with trisomy 18 and 13 that present themselves as being screen positive for Downs. We have also exploited the differences between Downs and trisomies 18 and 13s to develop a specific algorithm for these chromosomal abnormalities that, for the same overall false positive rate, can now detect about 95% of trisomies 18 and 13. These differences are two. Firstly, in Down syndrome, free beta HCG is increased, whereas in both trisomies 18 and 13, free beta HCG is substantially reduced. And secondly, in trisomy 13, the fetal heart rate is very much increased. Other chromosomal abnormalities that have been identified through the first trimester screening program for Downs include triploidy. There are two types of triploidy: diandric triploidy, where two sperms fertilize one egg, and therefore there is a much greater contribution from the male. And in these cases, the placenta is molar, and the fetus demonstrates increased nuchal translucency. The maternal serum free beta HCG is very much increased. Because of these similarities with Downs, the Downs algorithm identifies more than 90% of the fetuses with diandric triploidy. In digynic triploidy, the nuchal translucency measurement is normal or even reduced, but free beta HCG and Pabay are very much reduced, less than 0.1 multiple of the median, and therefore, because of this factor, digynic triploidy is easily identified by the algorithm for trisomies 18 and 13. Another relatively common chromosomal abnormality is Turner syndrome, and in this case we have two types of Turners. We have the lethal type with a very much increased nuchal translucency, or what some people refer to as cystic hygromas, and in this type the maternal serum Pabay is reduced, and therefore again the condition can easily be identified from the first trimester combined test. We also have another type of Turner syndrome, which affects about 10% of the cases of Turner's, and in this case there may not be any features of a chromosomal abnormalities by biochemistry or by ultrasound that can identify these cases. And these are likely to be the cases of Turner's that may only be identified several years or decades after birth. Another benefit of the first trimester ultrasound examination and the measurement of nuchal translucency is that an increased measurement is not only a marker of Downs and other chromosomal abnormalities, but also it is a marker of many other fetal malformations, skeletal dysplasias, cardiac defects, and genetic syndromes. So the detection of a high nuchal translucency is inevitably followed by a series of investigations that go a long way towards identification of many of these other major fetal abnormalities and genetic syndromes. The ultrasound examination in itself can also detect many major and severe fetal abnormalities, including acrania, holoprosencephaly, exomphalos, gastroschisis, obstructive uropathy and megacystis, and the body stalk abnormality. And these major defects that are easily detected constitute about 30% of all major fetal abnormalities. A great emphasis is now being placed in the identification of other important major fetal abnormalities, and these include open spina bifida, which have traditionally been easily detected in the second trimester by the presence of the lemon and the banana signs, which are signs of the underlying presence of the Arnold-Chiari malformation. In the first trimester, these markers are not detectable, but in the mid-sagittal view of the fetal face, as for measurement of nuchal translucency and assessment of the nasal bone, we can now examine the midbrain and the brainstem, and we can easily detect or suspect the presence of open spina bifida by the increase in the width of the brainstem and the constriction of the complex made up of the fourth ventricle and cisterna magna. Major cardiac abnormalities constitute the most common cause of postnatal death due to congenital defects, and the overall detection of such abnormalities has been quite poor across the world. However, we now know that a very high proportion of such major cardiac abnormalities can be unmasked by the presence of increased nuchal translucency and abnormal flow across the ductus venosus and the tricuspid valve. There is some evidence that we can now suspect and diagnose, therefore, more than 70-75% of the major heart abnormalities in the first trimester of pregnancy. The first trimester combined test has also shifted the emphasis into the early prediction and prevention of many pregnancy complications. And the best example in this respect is the prediction of severe early onset or preterm preeclampsia, which can be effectively achieved in the 11th to 13th week assessment by a combination of a series of factors in the mother's history and maternal characteristics, together with the measurement of the mean arterial pressure, the uterine artery pulsatility index, and the measurement of maternal serum, placental growth factor, and PABA. We can also predict more than half of the cases of fetal growth restriction in the absence of preeclampsia by a similar strategy of combining factors from the maternal history with uterine and artery pulsatility index and the measurements of maternal serum, PAB-A and PLGF. We now know that a very high proportion of stillbirths, especially preterm stillbirths, are as a consequence of a combination of fetal growth restriction and preeclampsia. So early prediction of preeclampsia, early prediction of severe fetal growth restriction, and an intervention in the form, for example, of prophylactic use of aspirin will inevitably lead to a decrease in perinatal death. Against this background of the major achievements that we have seen over the last 25 years from the first trimester combined test, I want to now describe the introduction of cell-free DNA testing in maternal blood. I want to begin by explaining the process. In maternal plasma, there are millions of fragments of cell-free DNA. About 90% of these fragments come from the mother and 10% come from the fetus. With new technology, it has become possible to sequence these DNA fragments and characterize them according to their chromosomal origin. In the second part of the process, each one of these fragments is assigned to the chromosome of origin, and therefore we can get a very good idea of the proportion of the different chromosomes that we have expressed in maternal cell-free DNA. In pregnancies with Down syndrome, for example, since the contribution of the fetus to the maternal cell-free DNA is increased, the total amount of chromosome number 21 related fragments in proportion to the fragments from the other chromosomes is increased. And this has now become possible that we can effectively diagnose trisomy 21, trisomy 18 and 13, and an increasing number of chromosomal abnormalities by analysis of cell-free DNA in maternal blood. An extremely important prerequisite for effective screening by this method is that the proportion of fetal to the total cell-free DNA in the mother's blood is at least 4%. At lower fetal fractions, the contribution of the fetus is small, and in cases of chromosomal abnormalities, the extra small amount that will produce of cell-free DNA for that given chromosome in maternal blood is difficult to detect. We have also learned that the two main determinants of this fetal fraction are, firstly, the amount of the placenta present, reflected indirectly in the measurement of maternal serum PAB-A, and the maternal weight. Since we are discussing a placental product that is being diluted in maternal blood, inevitably the bigger the maternal weight, the lower the fetal fraction. In terms of the relationship with placental mass, unfortunately, in those chromosomal abnormalities that are associated with a very low PAB-A, reflecting a very low placental mass, the ability to get a reliable result from cell-free DNA testing may be less. In the last 3 years, we have seen the publication of a large number of clinical validation and implementation studies using cell-free DNA analysis in maternal blood. we have put together all these studies, and the combined result indicates that the detection rate from cell-free DNA analysis for Down syndrome is 99%, and the false positive rate is 0.08%. I want to now explain the implications of this finding in relation to the methods of screening that we had in the past. I start by assuming that you have a population of 100,000 pregnancies and that the overall prevalence of Downs in such a population is about 1 in 500. And therefore we expect to see about 200 fetuses with Downs. When the method of screening was maternal age, we could detect about 60 out of these 200 fetuses with Downs, a detection rate of 30%, and a false positive rate, which translates into unnecessary invasive testing, for about 5,000 pregnancies. With second trimester serum biochemistry, the detection rate improved to about 60 to 70%, but the false positive rate remained at 5%. With the first trimester combined test, we had a further improvement to a detection rate of 90%, or 180 of the 200 fetuses with Downs, and the false positive rate again of about 5%. And when you combine the first trimester combined test with the additional biochemical and biophysical markers, we can get to a detection rate of 97% and a reduction in the number of unnecessary invasive tests to 3%. By comparison with these methods and these substantial improvements over the decades, the introduction of cell-free DNA analysis has changed things completely. The detection rate is extremely high and the false positive rate is extremely low. However, because the detection rate is not 100% and the false positive rate is not 0%, this is not a diagnostic test. And I take issue with the very name in which this test has been presented, either as NIPD, non-invasive prenatal diagnosis, or subsequently changed to NIPT, non-invasive prenatal testing. I think this name is unfortunate and it introduces an unnecessary confusion. It is a screening test. It is not diagnostic. Like all other previous screening tests, is non-invasive, so there is no need to call this a non-invasive screening test because none of the screening tests is actually invasive. It also means that the diagnosis that is given by the test is not certain, and if a fetus is suspected of being chromosomally abnormal as a result of cell-free DNA screening, this would need to be confirmed by invasive testing. And also, parents should be informed that exactly because the test is not diagnostic, the results may be negative, but very rarely, but it happens, the baby can still be affected. In this slide, I want to illustrate the consequence of receiving a positive result from cell-free DNA testing and how the result is actually affected by the prior risk that a given pregnancy has. Let's start again with these 100,000 pregnancies that contain 200 fetuses with Downs. We carry out cell-free DNA testing in the whole population, and the results are positive for 99% of the fetuses with Downs, but they're also positive for 0.08 of those that do not have Downs. So the cell-free DNA test will give us a positive result not only for 198 of the 200 fetuses with Downs, but also for 80 normal fetuses. So at the end, we get a result from about 280 cases that suggest that the baby does have Downs, but in reality, only 2/3 actually have this condition. I now illustrate the consequences of offering cell-free DNA testing to women that have extremely low risk for having an affected baby. The lower the a priori risk, the less is the chance that a positive cell-free DNA test will actually be truly positive. So we offer cell-free DNA testing in a woman with a background risk of 1 in 10,000. The result comes back as being positive, but in reality, only 1 in 10 of such fetuses will be truly affected. Cell-free DNA testing has also been applied for the diagnosis of trisomy 18, and the performance of screening is very, very good, but not as good as that for Downs. The detection rate is about 96 to 97%, and the false positive rate is 0.15. One could argue that this is brilliant, and it is certainly extremely good compared to what we had before, but by adding in our desires the detection of trisomy 18, which is a lethal chromosomal abnormality, we have now trebled the false positive rate from 0.08 to 0.08 plus 0.15 for trisomy 18. Good results, but much less so, have also been obtained for trisomy 13. Here, the detection rate is lower, about 92%, and the false positive rate is 0.2%. This slide summarizes the results of the meta-analysis of all of the studies that have been published on the clinical implementation and validation of cell-free DNA analysis for the detection of trisomies 21, 18, and 13. The blue band demonstrates the overall detection rate, the red one, the false positive rate. I want to draw your attention to the positive likelihood ratio, which is essentially derived by dividing the detection rate with the false positive rate. What this means is that when we get a cell-free DNA result suggesting that the fetus has a given chromosomal abnormality, the prior risk, the background risk, is increased by this factor. So in the case of Down syndrome, the likelihood ratio is more than 1 in 1,000. In the case of trisomy 18, it's about 650, and in the case of trisomy 13, it's about 450. So, again, the point that I made previously. If you had a woman that had prior screening, let's say with the combined test, and the background risk was 1 in 1,000, and the cell-free DNA test comes back as being positive, it is very likely that the fetus will be affected. If, on the other hand, the background risk was 1 in 20,000, even an increase in the likelihood by 1,200 would still leave you with a result where the majority of the suspected affected fetuses are actually normal. The next point that I want to make, which is perhaps even more important, is that of the negative likelihood ratio that I summarize here as a factor by which we divide the prior risk if the result is negative. So if we get a cell-free DNA result suggesting that the fetus is not affected, the background risk for a given woman is reduced by a factor of 1,000. So whatever the starting risk actually is, if she had a prior risk of 1 in 2 from, let's say, the combined test, and the cell-free DNA test comes back as being negative, her risk has now been reduced from 1 in 2 to about 1 in 2,000. However, because cell-free DNA testing is not as good in the case of trisomy 18 and even less so in the case of trisomy 13, the negative likelihood ratio is much less. The risk factor by which we reduce the prior risk is much lower. In the case, for example, of trisomy 13, this reduction in risk with a negative result is only 13. So if in the first trimester combined test the risk for a given woman for trisomy 13 was 1 in 2 and the cell-free DNA test is negative, the risk has been reduced from 1 in 2 to 1 in 26, but such a woman is still at a substantially increased risk of having an affected fetus. With these results in the background, I want to discuss now the possible models for clinical implementation of cell-free DNA testing. The first model is to offer universal screening, first-line screening with cell-free DNA testing. We have shown that it is by far the most effective method of screening, so why not offer it to everybody? Well, the answer is very simple. Unfortunately, at present, the cost is extremely expensive. It ranges in price from $800 to $2,500. So it is comparable in cost to that of invasive testing, and it is considerably higher than that of any other screening test. But if we were to offer cell-free DNA testing routinely to everybody, essentially the model would be to confirm a positive result by doing an invasive test, to reassure those with a negative result that it is extremely unlikely, but not impossible, that the baby would be affected, and in a subgroup of patients where the cell-free DNA test fails, then it can either be repeated or we can fall back to the results of the combined test and then decide on invasive testing or against based on the results of the combined test. We have estimated that with this first-line screening using cell-free DNA as the test, the overall detection rate for Downs would be about 98 to 99%. The detection rate of trisomies 18 and 13 would be less, at around 95%, and we would still need to do an invasive test in about 1% of the population. Should the test become cheaper, or for those women that want to pay for the test irrespective of the cost, when would be the best time to offer the test? I believe that in order to retain the advantages of the combined test that I have already discussed, the best approach for offering universal screening with a cell-free DNA test is to do an ultrasound scan and take a blood sample at 10 weeks. The scan is important to confirm whether the baby is alive or not, whether there is one or more fetuses, and to confirm the gestational age. and then we take the blood sample that we send off for cell-free DNA testing. We give an appointment to all of these women for another assessment at 12 weeks, where we will be discussing the results from cell-free DNA testing. We will be examining the fetus for the measurement of nuchal translucency, for any major fetal abnormalities, and I believe we should also be taking a blood sample for at least PABA and PLGF to predict pregnancy complications. We have applied this model in the study of more than 3,000 patients, and I want to summarize the essential points that we have learned. The interval between blood sampling and receiving the results is on average 9 days. And in about 98% of the cases, we will have a result within the scheduled 14 days. The second thing that we learned is that in about 4% of patients, we fail to get a result, but in those women with such failure, if we were to repeat the test, in half of them, we will get the result the second time. So the overall failure rate is about 2%. The other thing that we learned is the striking difference in the way the results are presented. On the left, I illustrate the results from the combined test, and you can see that the chromosomally abnormal babies, the vast majority of them, will be in the high-risk group. In England, the cutoff that we take for classifying somebody as being at high risk is 1 in 100. However, you can see the black dots that are chromosomally normal babies, quite a few of which are also in this high-risk category. With cell-free DNA testing, we have the complete separation of the two groups of patients. The high-risk come up with a result of more than 99%, and the low risk with a result of less than 1 in 10,000. And that is quite easy to communicate to the patients and much less confusing or less worrying in those that fall within the intermediate risk group. The second model for implementation of cell-free DNA testing is to apply it at the back of another first-line method of screening. So we carry out the first trimester combined test. We reassure women with a low risk, and in those considered to be at high risk from the combined test, we offer them cell-free DNA testing rather than invasive testing. Many of the professional bodies have advocated this approach, which I think it is the completely wrong approach to adopt when a new method of effective screening comes about. Why? Because we will have missed many of the chromosomal abnormalities that we now miss with the first trimester combined test, and in addition to missing those, we will miss a few more that would have been detected if we offered these women an invasive test. The overall performance of screening is quite poor. The detection rate is less than 90%. It's close to 85%. And the main advantage of this approach is that we are substantially reducing the rate of invasive testing to maybe less than 0.5%. The approach that I believe is the best in introducing cell-free DNA testing, certainly at the moment with the high cost that this test entails, is to use it as a second-line screening after first trimester combined testing, but now we divide the population into 3 groups. An extremely high-risk group with a risk, let's say, from the combined test of more than 1 in 10, where these women should be offered an invasive test. In this group, there would be many chromosomal abnormalities beyond the traditional trisomy 21, 18, and 13, and the chances that there would be a chromosomal abnormality are extremely high. The overall population that would require such treatment is only 0.5%. At the other end of the spectrum, about 75% of the population that have a risk of less than 1 in 2,500 can be reassured that they may not require any further screening. The group in the middle with an intermediate risk of, let's say, 1 in 11 to 1 in 2,500 can be offered cell-free DNA testing. If the test is positive, they are given an invasive test. If the test is negative, they are reassured, and if there is no result from cell-free DNA testing, it can either be repeated or we fall back to the results of the combined test. With this approach, the detection rate of all 3 major chromosomal abnormalities is about 97%, and the overall invasive testing rate is only 1%. Why should we not be offering cell-free DNA testing to women with a risk of less than 1 in 2,500? The number of cases with Downs in this group is extremely small, and the overall cost for each case, additional case of Downs detected, is extremely high. If cell-free DNA testing is in the region of $800 per test, the detection of each additional case of Downs would require the payment of $10 million. Even if the cost of cell-free DNA testing is dramatically reduced to, let's say, $200 per test, we would still need to spend $2.5 million for each additional case of Downs detected. In this slide, I illustrate another concept, and that will be the driving force behind insurance companies and governments that will be providing a healthcare process for the whole population. This slide illustrates that we can adjust the intermediate risk group according to how much money we have to spend on cell-free DNA testing. And for example, if instead of using a bracket for the intermediate risk from between 1 in 11 and 1 in 2,500, we were to reduce it to 1 in 11 to 1 in 1,000, the number of cell-free DNA tests would be reduced from 25% to about 15%. The penalty from such reduction in the proportion of the population offered in cell-free DNA testing would be a reduction in the detection rate by about 1%. Another strategy that I would prefer is that we improve the primary method of screening, the combined test, by including the measurement of serum placental growth factor and AFP, and including in the ultrasound examination, in addition to the measurement of nuclear translucency, the measurement of the ductus venosus pulsability index. We can then retain a very high detection rate, but we can substantially reduce the proportion of the population that would require cell-free DNA testing. Cell-free DNA testing has also been successfully applied in screening in twin pregnancies. The results are in general similar to those of singleton pregnancies. However, the total number of cases that has been examined is very small. We will have to wait for much bigger studies to see how the real performance is. I now want to discuss the implementation of cell-free DNA testing for screening for chromosomal abnormalities beyond trisomies 21, 18, and 13. One of the companies that uses a different approach to the analysis of the samples has been able to detect triploidy. They can detect diandric triploidy quite effectively, and they can suspect the presence of digynic triploidy by the presence of an extremely low fetal fraction. Remember, this is the type of triploidy where free beta HCG and PABA are less than 0.1 multiple of the median. An increasing number of studies are reporting their results for the detection of monosomy X. The results are not better than those that can be achieved by the first trimester ultrasound examination alone. And the question really is whether it is valuable to detect monosomy X in babies that do not have increased nuchal translucency. There are also a few reported cases that have been examined in relation to sex chromosomal aneuploidies other than Turner's. The number of cases is extremely small that has been published. Therefore, it is really impossible to know the true detection and false positive rate. The only thing that is becoming quite clear is that companies that have published their results, the failure to get a result is much, much higher in the case of sex chromosomal aneuploidies rather than in the cases of trisomies 21, 18, and 13. Another point that I want to make relates to the value of detecting these sex chromosomal aneuploidies. Many are not associated with any handicap or only mild handicap. In many countries, when these conditions are detected coincidentally as part of invasive testing for other reasons, the majority of the parents choose to continue with the pregnancy. If we are to offer screening for sex chromosomal abnormalities, I see two major problems. The first, this must become part of an expanded process of counseling the parents, because it is one thing to counsel a parent if you have found coincidentally one of these sex chromosomal abnormalities as part of an invasive testing process for Downs, and it is another now to counsel the whole population about the clinical significance and the implications for each one of these sex chromosomal abnormalities. The second problem relates to the high failure rate. The last few months, two companies have introduced cell-free DNA testing for the diagnosis of certain microdeletion, microduplication syndromes. These conditions, apart from DiGeorge syndrome, are quite rare, and this may be considered a major advantage, the ability to diagnose these additional conditions, but it can also be seen as a new process that introduces new problems. Firstly, not all of them can be detected. The performance of screening is considerably lower than that of screening for Down syndrome. And secondly, we are adding further additional false positive results. These are the results also from the second company that has introduced cell-free DNA testing for the detection of microdeletions and microduplications. I want to complete this presentation by summarizing where we are and where we have been. Screening for Down syndrome with cell-free DNA testing has a detection rate of 99% and a false positive rate of 0.08%. This is a great advance because by comparison with the best previous test that we had, the combined test, the detection rate was 90% and the false positive rate was 5%. We then begin to add the detection of other chromosomal abnormalities. We add trisomy 18 and trisomy 13. The performance of screening is good, but considerably lower than that for Downs. And in the meantime, we have added further false positives. So the addition of trisomy 18 and 13 to screening purely for Downs has now given us an overall false positive rate of more than 0.4%. Then we have the issue of adding the various sex chromosomal abnormalities with a lower performance of screening in terms of detection and an addition in the false positive rate to more than 1%. Furthermore, in 5 to 10% of the cases, there will be no result. And it is uncertain what the parents in such cases would do. Remember, we would need to counsel women of the advantages of screening for monosomy X and the other sex chromosomal aneuploidies. In a sense, we will be worrying the parents as to whether their baby would have one of these chromosomal abnormalities, and then if we fail to give them a result, we may well be stimulating them to have an invasive test. We have added the microdeletions and microduplications. The exact performance of screening is still uncertain, and we are now adding a further false positive rate which is beginning to approach overall to that of the combined test that we had in the first place. I consider these as important advances. However, they need to be thought of very, very carefully before they are being widely introduced. It is absolutely certain that screening for Downs with the new approach is excellent. I believe that the best approach to universal screening for this chromosomal abnormality would necessitate the combined test as a first-line method of screening, followed by cell-free DNA testing for the women in the intermediate risk group. The discussion in relation to the other chromosomal abnormalities is only now beginning. Thank you.